You said people are hungry for a healthier life.
People are looking for it but don't know how to do it, and so there's this innate hunger of, I want to live a better life, I want help in that way, and I want it in a way that's going to be for me.
More than 73% of Americans have overweight or obesity, while more than 12% have food insecurity. America is getting heavier, sicker, and more isolated from each other every day. Our motto, Move, Eat, Give, reflects our belief that virtually every problem in America could be fixed if we took better care of ourselves and took better care of each other. Welcome to Interrupt Hunger's Move, Eat, Give podcast, where we talk with experts in exercise as medicine, food as medicine, and food insecurity. And understanding that knowledge isn't always enough to help you lose weight. Every other episode showcases someone who's lost at least 10% body weight to share exactly how they did it. Interrupt Hunger is a 501c3 nonprofit which helps you lose weight while feeding the hungry. Bring our free 12-week weight loss challenge and donate your weight program to the places you live, work, and pray. We fund our mission with sales from our Move, Eat, Give bracelets and clothing, so please visit us at interrupthunger.org to show your support. 50 meals are donated for every item sold to the nation's largest hunger relief network. So you get to look good while feeling good. Now on to today's episode. Hey everyone, Jolly here with Interrupt Hunger. Today we've got Sami Mansfield, founder of Cancer Wellness for Life, with us today. It's an organization dedicated to developing, implementing, and optimizing exercise oncology and lifestyle medicine programs and resources for hospitals, healthcare organizations, pharmaceutical companies, nonprofits, and individuals impacted by cancer. Sami has contributed significantly to several state cancer control plans, emphasizing lifestyle, exercise, and obesity management strategies in cancer prevention survivorship. She's been busy over the last several years. She's helped author ASCO, American Society for Clinical Oncology, ASCO guidelines on exercise, nutrition, and weight management during active treatment, and the exercise recommendation for people with bone metastases. Sami is involved in several international lifestyle medicine organizations and is currently the chair for the Cancer Member Interest Group for the American College of Lifestyle Medicine. And with that, Sami, welcome to the podcast. Thanks for joining us today.
Thank you. Well, thanks for having me and part of this mission that you're on. It's fantastic to be here.
Oh, thanks. Yeah, I appreciate that. We talked last week, and I actually wrote down something you said. I thought this might be a good place to start. So you said people are hungry for a healthier life. And that is so cool. It just feels like it. It feels like a momentum is shifting coming out of COVID and the GLP-1 meds, people are talking about it more.
Yep.
So I think just the time is right for that.
It's interesting, sort of these things come out of your mouth. And like, I think I've been pondering that concept for a really long time. Not only just with cancer survivors, thinking about the patient perspective, but working with medical and healthcare professionals and organizational professionals. I think there's a lot of things changing in how we live our life, ourselves, as well as our community. And we're prioritizing things in such a different fashion right now. Looking at what is quality of life, I think a lot of us are thinking about, we started this career track, we started maybe a family track, whatever that is, to achieve or chase a goal. And then we kind of take a pause and think, what are we after and what does that mean for us in our daily life? And I think that there are so many strategies out there. I mean, you can Google or find anything, resources, research, whatever it is, about like how to do the quick fix, the this, the that, to have your, 5 breathing strategies in the moment. And that tells me is people are looking for it, but don't know how to do it. And so there's this innate hunger of, I want to live a better life. I want help in that way. And I want it in a way that's going to be for me, not just for something that is very much about my social media or what I tell somebody, randomly. So I think that the world is shifting a little bit on ourselves in that way. And I think that we have a lot of work to do in making that solution available. But I think that there's just this hunger happening out there and this passion, and why we're all excited to talk about these topics. Like, it's so much more fun than talking about research. It just is. It really does make an impact. So I'm excited to really have that kind of landing point and really align with your message with Interrupt Hunger, because it makes so much sense.
Okay. Yeah. I think people are just tired of falling for gimmicks, falling for influencers, all the shallow misperceptions and myths, and like just get back to like what's it mean to be healthy and just back to basics. Like it really is not complicated when you get down to it. Like finding what works for you is kind of the hard part, but yeah, very good. All right, so when I first got into this 12 years ago after getting diagnosed with type of leukemia, it was all about doing everything I could to stay alive as long as I can. So I dove into nutrition and exercise and found this beautiful field of medicine called exercise oncology. And we know some of the a lot of the same people, which is really neat. But then as Era of Hunger started forming, I kind of shifted outside of not just this niche of exercise for cancer survivors, but for everyone. And you've kind of done the same with your career.
Mhm.
You were one of the very first
Yeah.
back in like the early 2000s for really systematizing exercise for cancer survivors. So why don't you just tell us how you got started and yeah, we'll
Yeah.
take it from there.
It's always interesting to I get asked this question of like, well, how did you get where you are? And I don't know if you could duplicate my path if you tried because so many things have changed. In 2003, when I started, I was working in a community setting, I was working at a gym. And I was referred a woman who at the time was a 2-year cancer survivor. She had triple negative breast cancer. And for our audience, we're largely familiar with, the risks and also the prognosis of triple negative breast cancer being kind of one that you don't want to have, right? If things have changed in that, but in 2003, that was a pretty scary diagnosis. She had breast reconstruction that had gone awry. I mean, she had an implant sliding under her armpit. I mean, weird,
Wow.
crazy things and breast cancer related lymphedema, other concerns that we know now are cardiotoxicity, but we didn't really understand then. And she was referred to me. And when I first talked to her and I said, "Tell me about you," she started telling me all of these things that cancer kind of did to her physically and mentally. And she was really interested in exercising, didn't know where to start. And her last question to me was, "Do you think you can help me?" And at the time, I was like, "Well, of course, I'll figure this out." And I look back and think, I don't know if I was bold or I was a little crazy, but I knew innately, like many of us do, that exercise had one of the most powerful ways of helping somebody, but we didn't really have the evidence and we didn't have any recommendations. So a lot has changed in 21 years. Kim, the first person who started me in this field, is still a great friend of mine. She earlier this year became a grandma for the first time. I mean, it's exciting to see her quality of life and how she lives her life and how much she's influenced. But that is where I got my start. And I went to cancer centers and hospitals and said, "Hey, I have this idea." We ran community programs. We found at that time we had a lot of cancer survivors that were hungry for quality of life. They hadn't recovered after treatment. And we saw that passion and desire even before we had the evidence. So that is really where I started. And then I really moved my career into healthcare back in 2010, worked in community and academic medicine, and research, and started really looking at like, this is great and everybody knows it's beneficial, but how do we do it? How do we bring it in so exercise oncology could be part of the cancer care plan, whatever that plan looked like, even if it's just surveillance? And so I think that, looking back, we were ahead of the times, but in a way it was great because I think people were so excited about another tool in the tool belt, even if they didn't understand how to do the tool in the tool belt, right? So, but
Yeah.
we was always very supported from our oncologists, really from day one.
Oh, that's cool. So, on one hand, we've got like thousands of studies now.
Yes.
Thousands. It blows people away. We have thousands of studies in exercise for cancer survivors, whether it be prevention or doing active treatment, or the best part is cancer survivors who exercise happen to live a lot longer. And we're
Hmm.
learning more and more about different types of cancer. And then you've got the oncology, the providers on the other hand. And there is a really, really big gap in the middle,
Yeah, sure.
which you live firsthand. So why is it so hard to connect this incredible body of evidence with all the science with making it happen in
Getting
the
people going.
in the office.
So I think one of the things that we really should kind of start with is like, what is the disconnect? And I think that the disconnect on the external world is the perception or preference of exercise as far as a supportive, important tool for oncologists. And I think that often people think, well, my oncologist didn't tell me this, therefore they don't think it's important. And I would actually argue that in my 20 plus year career, there has been two situations, very specific experiences I can recall where oncologists push back against my recommendations. And, again, this is a long career. One definitely made a lot of sense once I had more information. I was very new to the field. And so it was kind of, that like a little bit more optimistic of what really this meant for this particular patient. And the second one was a miscommunication that we resolved. But what I go back to is saying is it's not that oncologists or advanced practice practitioners or even dietitians or whoever don't believe in this. But I think that we need to remember two things. Medical professionals, especially in oncology, and you know this, the field is evolving from a treatment perspective at a pace that I don't think we ever expected, as far as there's the cancer care plans that are coming out at rapid fire in diseases such as like lung cancer, where we didn't see progress for decades. And so they're focused on that scope of service, or not that scope of service. Let me backtrack. Oncologists are focused on delivering cancer treatment plans. What does the plan look like in 15 to 20-minute visits? That, when do they talk about exercise? Now, so I know that I know they're supportive, but they don't really understand it. They may not exercise themselves. They don't know how to refer it. Well, that's our job in exercise oncology. So I think that's one of the disconnects. The second disconnect, and we know this, we do not have enough resources available for physicians or cancer community programs, I don't care who you are, to even refer to. And especially if we think that most patients should have supervised exercise. And I think that while probably 100% of our patient population would benefit from supervised exercise, necessity kind of has a little bit of a different discussion point for me. So I really feel like one of the disconnects is the lack of understanding of what the clinical cancer treatment day looks like, in us recommending exercise. I mean, as an exercise oncology professional, there is not a no way I would assess someone and give them recommendations for exercise in 15 minutes. But our oncologists are assessing and recommending and treating our patients sometimes in 15 minutes.
Yeah, right.
And so I think that we should be mindful that maybe they can't fit it in, and that's our job. And that's our job to build, as you're doing, community resources and education that sort of bridge this gap. And I think my other concern is we create silos, both silos in how we build our cancer care teams, but silos by disease type. And so I used to think, is somewhere in my career, we're going to have a breast cancer exercise plan, and it's going to be laid out. What does someone with breast cancer do at this time point with this treatment? And then everything has changed and evolved and moved forward. And I don't think that that's reasonable to be giving exercise prescription based on cancer type, because everybody is different. And so I think that now it really changed the lane where research has often gone by cancer type, and that's funding and support and clinical experience and things like that. But I think those are a couple of the disconnects. However, I really believe we're at a space now, to your point, people are hungry for this information. Patients are starting to ask, their caregivers are starting to ask, and organizations are starting to put this in all areas of support. And so I think that's really exciting when you go to an organization, maybe a blood cancer organization as an example, and you see this section on the website that includes lifestyle. So we've made a lot of progress, but I think we need to keep kind of talking about how to work together and how to make things more accessible and available, both in time and dollars and knowledge and things like health literacy, that all are important barriers.
Yeah, this is fascinating time. It's we having to raise awareness, raise the noise with both the patients, the community, the general population at large, and the providers and the health systems all at the same time. But it's getting there. So why don't you kind of share some of the successes that you've had. Where did you start? And then whether you want to go into, your consulting services or what you're doing now, or I'll just kind of let you lead the
Yeah.
conversation.
Absolutely. I think I can say from looking back in my career, I had so many really successful conversations and opportunities working in the different aspects of cancer care. Again, whether it was being an employee at a community based cancer center or an academic medical center where I ran a cancer exercise clinic, I had so much fantastic experience. The reason I moved to being a consultant was I realized when I was on the front lines, when I was running my own clinic, as many of our clinicians feel, that you only have so many hours in a day and you're taking care of the hottest fire in front of you. And you can't really make change. However, being in that front lines, I was able to sit at the table with other allied health colleagues and support service teams, with other multidisciplinary teams, and attend things like tumor conferences where we hear everything from diagnostic readings, pathology, genomics, and treatment plans, and kind of come forward and say, wait a minute. How is this person functioning? Where does that come into the lens of working up the whole patient? And until you sit at those tables and understand that process, it's really hard to identify, in my mind, solutions, because otherwise you're kind of on the outside, which is, I think, where a lot of our colleagues end up. There's not as many integrated programs, or they're siloed off. So I had really great seats at the table, from C-suite administration right on down to administrative scheduling staff, to really look at the process of what our patients go through, and then understanding how to implement. Looked at, all right, what's important to a cancer program? Credentialing needs. We want to keep our patients out of the ER. We don't want them readmitted, process. Where do we fit in? And I think that that really was a great lens for me. And the advice I give someone is, I think that rather than tell someone that exercise is important, I'm pretty sure most people know this. I don't care if you're a clinician or administrator or a scheduler, whoever you are in cancer care, a nurse. It's more, how do we talk about the hows? Like, how do we talk about integrating this in? And I think that was a unique position I had. I learned very, very early on that Sammy was not as well received if she was the exercise person, because it was like, wait a minute, what are you here? What are you making me do? Even with staff, I'd come to staff meetings, and rather than have someone do, a ton of exercises, we would talk about balance or mobility or things that people thought, we're a little bit more warm and a good introduction, right? Than here's 10 squats. We usually got to the 10 squats, but that's not where I started. So one of the advice, principles I give people is, fit into their mold. Don't always make people fit into yours, because we have different biases, maybe of the types of exercise or the modalities. But unless we can speak a language that makes sense to somebody else, it's hard for them to really listen to you and without their own biases. So I think that's a really big piece that I learned, both operationally as well as relationships, from the different aspects of my career. But the reason I also changed my direction is I realized that without all of the other pillars of lifestyle, if we didn't talk about nutrition, sleep, and stress management, people were either exercising or they weren't. And
Hmm.
if they weren't exercising and they weren't doing anything else, we were not making forward progress on their lifestyle. And so I realized that the most successful way to support individuals with cancer, caregivers, my clinician friends, and colleagues was to really look at the six pillars of lifestyle. One being just avoiding unhealthy, risky behaviors, not just alcohol and tobacco, but physical inactivity or added sugars, which we know are harmful, right? So I really decided that I was going to make a very strategic move to not be such a specialist in just one pillar, and take a step back and make sure that we were delivering all six of these pillars in a way that people could access, understand, and most importantly, implement, no matter who they were, no matter where they lived, no matter what their budget was, and maybe where their, health literacy is. And I think we've talked about this. People know of all socioeconomic classifications the importance of lifestyle. Doing it is where the challenge is. And I think where the work that we're doing is really making some momentum, because these are populations that once they have the knowledge, get really excited, and really continue to make change. So that's kind of why I changed. Not right or wrong, just fit where I'm at in my career.
Yeah, I'm probably going to say this to like every single clinician or allied health professional I talk to from now on. I think everybody eventually is going to be a lifestyle medicine specialist and an obesity medicine specialist. It
That's
just
right.
that you could just again, you just feel that's the direction that we're going. It's you're a whole person. You don't have cancer over here and sedentary life over here. Your diet full of ultra processed foods over here and no sleep at the same time. It's everything works together, obviously.
That's
Okay,
right.
so I've heard we'll kind of tackle this two different ways. So I've had a fair amount of oncologists say when it comes to an exercise referral,
Hmm.
one, they don't know anything about it and they're
Hmm.
scared to look
Hmm.
silly in front of their patients, which is a very real concern because you definitely want to have the confidence that you know what you're talking about. You're the
That's
expert in the
right.
room. And then the other thing I also hear is they're scared that they don't want to hurt their patients.
Yeah. Agreed.
So, and then I guess the third bucket would be how you pay for it. So those are really the three big buckets that are preventing us. And it's not just, exercise for cancer survivors. This is just any type
In
of,
general.
yeah,
Yeah.
health system.
So I think that we are in such a great place right now. You mentioned earlier, as far as like just even my introduction, two really great projects that we finally, launched in 2022 were the ASCO guidelines. Those were actually the during treatment guidelines. So anyone undergoing, any cancer survivor undergoing treatment of curative intent, that was just the parameter that we use for these guidelines, should strive to meet exercise recommendations. Now, I think that we should shelve the exercise recommendations number for a moment and just focus on the time point. That was the first guideline internationally that came out that looked at a very specific on treat population. Then the metastatic recommendations, which are a little bit different than guidelines but are more of an encouragement tool, looked at the bone metastasis population. And one of the biggest things that we found through the literature, which was global, was that the risks of inactivity, right, outweighed the risks of inactivity. No, yes, the risks of inactivity, if I can say this, had a balance effect of like the risks related to potentially hurting someone with exercise. There were more benefits to exercise, right? Than, being too protective to our patients to not exercise. So what we learned was we needed to encourage these patients with metastasis to exercise. The caveat I would say, and I will continue to say this was definitely through the literature, was that is a population that we recommend supervised exercise across the board as a starting place, even if there is no pain with the bone met. We just do. Now, I think then we move forward to the general exercise recommendations from oncologists. One of the reasons I think that they're scared is oncologists are used to being prescriptive. What do you do? How much do you do? I think that we need to continue to be confident that we're not asking for prescriptive for oncologists. We're not asking them to make any sort of specific recommendations. Some do, some don't. But all we're looking for is a green light. This is important, and here is how you do it. And I don't think that we as a field have done enough of that for our oncologists just to really push the fact that we're just asking for a green light. They don't need to be prescriptive. They just need to give the green light using whatever guidelines, recommendations, American College of Sports Medicine, the Moving Through Cancer Initiative, whatever they are. The third piece about this is paying for it. I think we need to think through this very thoughtfully, that exercise in the general concept is free. Movement is totally free. And I would argue the most accessible lifestyle medicine pillar that exists, because you and I can sit in the chair and we can get in movement, right? We don't need equipment, we don't need anything fancy. We can get in movement that is planned, which is now defined as exercise. Where the payment side comes in is for supervised exercise, which in key populations is definitely important. But I would argue, is it necessary? And in some situations, probably, but a lot of necessity I think could be debatable. I think that we could give better exercise recommendations that could be modifiable. As an example, if someone has neuropathy and balance challenges, and I can't get them to go to a supervised exercise session, then I'm going to give them a chair-based exercise. And I'm going to educate them on why I'm giving them chair-based exercise or maybe just very supported exercise. And I think that's hard for people to say, like, well, what if they hurt themselves? Honestly, most people are going to do less than to go hurt themselves,
Yeah.
right? And are we harming them by not having them be active and then they fall, right? So, I kind of would argue that. Now, I do feel we are making significant progress, and I suspect that we will continue to grow the field, both of exercise oncology professionals that have cancer training, rehab professionals with cancer training, more community professionals with cancer training. And in some of these scenarios, we can get reimbursement, and I do suspect that's growing. I don't know if we're going to see significant coverage changes in the next 5 years in combination with workforce to really see the outcome of that. So, in the meantime, the question I ask myself is, if we have an estimated 18 million cancer survivors now, where are we going to be in 5 years? 22-ish is sort of the estimate, maybe 23.
Yeah.
I'm not exactly sure on the
Very
data.
fair.
What about all of these people? So I think that we should be able to tackle this in a multifactorial way. But again, I think about this is where lifestyle can really come into play. If someone is sleeping better, they're going to have more energy. They're going to be more likely to engage in activity, exercise, and even go to supervised exercise. They're going to be willing to have a little more skin in the game. So I think that thinking creatively about this is important.
Yeah, got it. Okay, so someone in a administrative high level position or maybe a clinician comes to you and they've talked to some of their peers in a hospital, a
Mhm.
medical practice, or a health system, and they obviously see the benefits of this, and
Right.
they want to they want to start a program. You can generally speak or talk about your programs as much as you
Yeah.
want. How does that happen?
Well, there's a lot of different ways. I think it really depends on what does we have to define a program, right? What does a program look like for people? We think about sometimes programs really look like just delivering a way that we're implementing the education and the referral to resources within the clinical care practice. So a lot of times we, as a consulting, build in how do we assess a patient for functional needs that we would refer to exercise, rehab, or community. And we have validated tools in the space of exercise and rehab that we can assess the patient's need. So sometimes we build in the education. A lot of times cancer programs that we work with, whether they're in the community, they're academic, or they're even a support organization, all they have is you should exercise 150 minutes of moderate physical activity per week. People are like, what does that mean? So part of it is just building in the what does that mean in a way that can now be implemented, and then helping to identify where are the processes we can implement. Chemo education is a great time point, right? Um, what is the piece that needs to go into that time point? And then most importantly, especially because we started this with administrators, how do we measure the impact and the success? So we need to make sure that whatever we're doing, we measure. We measure this in patients that are increasing their compliance to exercise and physical activity. We can measure it in fatigue. We can measure it in falls. We can measure it in distress screen. There's a lot of tools to measure it. Look a little different, but I think that those are some programs. We have programs that we have helped train staff, exercise oncology staff, or other types of staff. So sometimes we train nurses. It's not in a perfect solution, but gives us another sort of foothold into what's already happening, what's already built, and making sure exercise becomes part of that. And then, of course, there are definitely systems that we built programs for that have been fully staffed with exercise professionals. If we in the current landscape are going to do billing, they need to be rehab professionals. That's just the current landscape if we're looking in the United States. For our global partners, I mean, those are going to be physios, right? Which is the version of our community. But if we want something that's billable, that's the tool that we have right now.
So, sorry,
Yep, go ahead.
are
Yeah.
you talking specifically about like a DPT, or is this just like a master's level exercise professional?
So I've staffed both, but I've also staffed both that, we have not billed for all of these services, right? We've just built these individuals in and then the health systems have paid for it. If we want reimbursement, then they have to be somebody like a DPT.
Oh wow.
Yeah.
Okay. All right. I didn't realize
That's
that.
and I think that we need to be really thoughtful about this. If and we build it into an ideal world, supervised exercise prescription in an ideal world is probably going to be more than once a week. We need to think about this from like a copay side of things, right? And that's just another challenge, a scheduling side of things, 8 to 5, Monday through Friday, or whatever that is. So I think that we need to be very thoughtful about broad implementation. And as you and I talked about before, we mentioned scalability. In order to really make change, we have to have scalable interventions that aren't considered to be kind of concierge. So, scalable needs to have a little bit less guardrails in my mind than the typical clinical schedule and access that happens. When I was running an exercise oncology clinic at an NCI cancer center in Kansas City, my wait time or my wait time to appointment was over 30 days for one
Mhm.
person.
Wow.
And I was kind of new to the practice. Exercise oncology was new. This was 2012, and we were just growing. The census for one of the busier clinics, I'd see 12 to 15 patients a day. The census that day was over 400. And one of the reasons that I really left working in that field was I remember and having a good cry over this. What about everybody else? And there was no answer. There was no solution. There wasn't really an opportunity to even bring in education and bring in partnership with, our rehab teams. And because I was too busy in that frontline day to day, all of the things that come with clinical care. And I thought, this is not going to be successful. And the scalability option at that situation was hire another me. They didn't bill for my services. So there was not going to be a hire another me. So that's when I really started to realize we had to think very strategically about how to make this successful intervention. And also for me as a professional, anybody that's listening that has to chart and do things in the EMR, they're nice for accessing information. They are a lot of work. Like charting and documenting notes take a lot of extra time for us. So we need to think about that strategically when we're asking our clinicians to do more. How does do more not mean do more in time, but do more in making a referral or do more in giving information to a resource? I think doing more shouldn't, correlate to more time for them. And I think that's
Yeah.
one of the barriers that we run into.
Yeah, that makes a lot of sense. I'm thinking there's going to be clinicians listening here, and there's going to be just general Laker people listening here. And if this only happens, to your point, by an exercise professional, like I mean, it's not a lost cause, but there's so many. I mean, there's
Yeah.
exponentially more people. So, what if a not just an oncologist, but general practitioner or pediatrician or any type of specialist, like how is there a way for them to bill for this, or is there a way for even just an initial assessment? There's some amount of time. You've got the physical activity as a vital sign, and a couple things that are getting out there more, but like healthcare, flexible spending accounts, or how does it at the smallest level, even maybe somebody in a
Mhm.
rural setting, they don't have access to a world class
Mhm.
facility or any kind of facility, but they want to help their patients. Like, how does that? How does it actually
Yeah.
happen?
So, I mean, I think there's some creative ways around this. We have plenty of colleagues in various professions, whether they're oncologists or APPs or primary care, or to your point, right? There's lots of oncologists. Many of my obesity medicine colleagues are delivering in exercise, and to the point that we're kind of talking about, broad lifestyle as part of their visits. So professionals can do that. That's why people get certified by organizations like ACLM or other functional medicine to deliver a certain amount of care. If you deliver let's say I'm a primary care advanced practice practitioner. Let's go more specific. Let's say I'm an oncology nurse practitioner and I'm delivering care in a cancer treatment center. I can deliver lifestyle medicine tools and strategies under my care. I can do it as long as I, am delivering the scope of my service as far as a clinician. I can still give the exercise resources. There are some nuances about how prescriptive you can be in each of the disciplines based upon your training, right? And your scope of your practice of where you are. So of course that's going to be built for, or you can bill for that. There is also some groups that are doing shared medical visits. We see this mostly in primary care. We see this in chronic disease management, especially in the Medicare population. We've got some really successful people doing this in a handful of clinics that have built in a great model with nurses and care coordinators and are, very viable financially. However, that's a complex system that then how do you go from I'm a busy clinician to I'm starting a whole practice? You've got to have a gap, right? For a lot of people, I think the best thing to do, I think there's two things to do. I think one, can you fit this education piece in your current scope of service, no matter where you are? I think that some clinicians do. It really depends on the practice and what maybe their RVUs look like, right? If they have the time and they have the resources, whatever that is. I did some work for some education with the American Academy of Family Physicians, looking at obesity and survivorship, kind of bringing these pieces together for primary care who were caring for patients post treatment. And yes, we have the survivorship care plan, your little summary document of your treatment. But in the family practice or the internal medicine side, they weren't really sure, like, okay, what do I do with that outside of what I do now? And what we learned was if we could build them a toolkit, right, which is a lot of the work that I do, that they just have to plug and play the toolkit. They can now have a conversation because I have a resource right in front of me. Meaning I can introduce knowing that here's my resource, because that patient's going to go, yes, I'm interested. Where do I get information? And we have the where already built. The reason I created Shift in our whole lifestyle program to be a resource for clinicians. Yes, it has a patient-facing side of it, but most of the buy-in is coming from providers, clinicians, various colleagues in medicine who talk to patients about lifestyle, talk to patients about weight management, talk to patients about resources and don't know where to refer them. Where we need tools that are based off cancer recommendations, not just general broad recommendations. I mean, yes, they're valid, but utilizing the American Cancer Society recommendations and the American Institute of Cancer Research recommendations are much more important in my mind than just generally, healthy behavior change for the general population. So I think that was one thing I really realized is most of our clinicians said need a resource, but there wasn't a resource, and I think that was really one of the gaps that I saw was building little resources was okay, but I needed to build a resource that could be a very broad resource. And so that's kind of why I went that direction. Actually, it's mostly why I went that direction because we needed to use trusted evidence. It's really important for this population that we follow the guidelines as much as possible, but in a way that makes sense if you're in rural Mississippi or you're in Maine or you're in Denver, whatever that is, right? It should be generalizable in that way.
Yeah, sure. So let's see here. So you said APP, I think I mentioned it too. For those listening, it stands for an advanced practice provider, like a nurse practitioner or a physician assistant. Are they the best person to have this conversation with?
I mean, I think you always need physician buy-in, which actually I would argue it's really easy to get. When I worked in clinical practice, and I would say any of this, exercise oncology, when we go to the clinicians, I would go to the clinicians and say, hey, listen, is there any situation or any person or any criteria that you want me to come back and get your permission to give exercise recommendations to? And this could be for a neuro-oncologist or, someone who deals with brain tumors or someone who deals with blood cancer, whatever. And it was very rare that someone said, "Oh, I really need you to talk to me about this situation." Now, when I needed a rehab referral, I need them to write the order, but mostly they'd have a pre-approval so the nurse could help me with that, right? To help as we know, clinicians, we need buy-in, but they're very busy. Most of them are like hands off. They prefer to their advanced practice practitioners. The conversation with those clinicians, in my mind, is less about the what it is and more about the how we do it, because they all get the why and the
Yeah.
what, but I think it's the how. I
The
think
how is
that
the hard part.
yes, but I think that, to your point, I think that this is a group of professionals that tend to have a little bit more time with the patient. They're allotted a little bit longer time. They maybe do kind of follow-up visits or supportive care. And I tend to feel that they're very engaged in this as well. And they're very into resources. They tend to be sort of that driver of resources, not just tasks and not just prescriptive. So I think they're some of the best. But I also think like partnerships with nutrition, if you're an exercise professional, I mean, I have a lot of nutrition training, but not a lot of exercise professionals do. They can be great resources. We think that they aren't sometimes, but I think that there's a lot of collaboration that can come, and rehab professionals can be another great resource as well. But I think building any relationship is key. I think that makes a huge difference to your success.
Yeah, of course. Two questions here.
Mhm.
First of all, I'll just kind of focus in from the patient perspective, how they pay for it. And then kind of a follow-up question is, and these are all businesses, like, just to be blunt, like what's in it for the hospital? Like,
Yeah.
where's the business side? So focus on like how does the typical patient pay for this? Do they have to come out of pocket, or at least for the initial assessment?
If they're doing supervised exercise, yes. I mean, you can, like you said, you can utilize some of, your health spending accounts, but it just depends on the professional. For some sole proprietors, it's just a lot of extra work that it's not really reasonable. So not every sole proprietor does it. Some do, but most people will cash pay and try to offer, groups or discounted rates or things like of that nature. For the health systems, when we work to build programs in health systems, we look at key metrics that are important to health systems. Yes, downstream revenue is definitely one. That comes from a couple of things. Interestingly, I mean, rehab is great. Downstream revenue, it's not really high volume, but it's pretty decent. If we can really build cancer rehab programs, they can pay for themselves. I also think that, we look at very key metrics such as reducing ER visits, which is really significant for our cancer population, hospital readmittance, length of stay. We have great evidence in all of these components, right? For the patient side, we also have great science that shows us that, as an example, meeting exercise recommendations, if we're going to look at the number, the 150 number, and that we talk about, reduces our out-of-pocket healthcare expenses and my overall general expenses. So it can be a savings account for people, but getting them from A to B, again, having people extend out of pocket, they may not have out of pocket cash. So sometimes, again, that's where we think about, okay, maybe you don't have a lot of supervised exercise, but can you go to a rehab therapist once? Can you pay for an exercise oncology visit once, get a plan, implement the plan, and then continue and come back? So there's not a quick fix to this, but I think that we do have enough research to show both cost savings, as well as some revenue for our particular health systems. And interestingly, we are starting to see that for employees. This is also another great tool that we engage with employees. So when I was working in health systems, I was very involved with employee wellness, and we would sort of sneak in, let's talk about the patients at the staff visits, and then we would do employee things as well. And employees would ask and we would engage in that. So there's some other ways to do metrics that, maybe aren't as fancy as a surgery, but are still very meaningful to health systems and can be measured. But we have to measure and do assessments. Otherwise, it's pretty hard to sell nice. You're kind of selling the cherry on top.
No, that makes sense. That makes sense. So you've done least let people about your program for a little bit because it's really pretty cool. So you've got a lot of virtual resources.
Mhm.
Just kind of share, like, talk about your program for a little bit.
So Shift is where I've taken the 6 pillars of lifestyle medicine, and we give anyone with cancer kind of the guidance on how to use the 6 pillars. So talking about those, so exercise, physical activity, nutrition, thinking plant predominant, but unprocessed nutrition is really our priority. We do stress management, sleep, social connections. Interestingly, a lot of our community is looking for social connections in this healthy lifestyle. Like they want other healthy friends. And then we talk about avoidance of risky habits or behaviors. And so we took all of these with the science of what do we know, what's impactful. We know that, as an example, there's not a curative food, but a certain dietary pattern makes a lot of sense, right? And we packaged it in a way that people can start to learn about how to implement these changes in their life, no matter where they are. And we teach people how to read food labels and how to utilize some of the technology to make making food choices at a restaurant or a grocery store easier. How to exercise, we give them exercise plans, and we have videos and content for any level of function. And, what do I do for sleep? What's my sleep routine? How do I manage my stress? Here's some practical tips on breathing. We make everything accessible. In my mind, the biggest thing that I want people to know is that if they do a program like this, it's not going to cost them more money. It's how do we utilize your time and your dollars differently? And I think that's really important for people because most people have such financial toxicity from cancer. And the majority of Americans don't have a lot of leftover dollars or time. And so that's really one of the reasons that we have focused on that particular modality. Isn't let's add more supplements. And in fact, for most people, I take them away. And let's think about what's meaningful. If you need to sleep, it's not about a supplement. It's like, what's your sleep routine look like? This is free and also sustainable. And I think that's one of the most important things that I've learned about lifestyle in my personal space. And maybe this is actually an interesting reflection, as we talk. Years ago, I had a practitioner who taught resilience training for cancer survivors and staff ask me, "What's your tool for resilience, Sami?" And as you may imagine, I was like, "Well, I exercise." And she's like, "That doesn't work like that." I was like, "What do you mean? I feel good." And, this is probably in my 20s, right? But hey, I thought I had it all figured out. And she said, "But wait a minute, what do you do when you're in a meeting or, you're waiting for a doctor's appointment or, you're on a plane somewhere, whatever it is, you're stuck in traffic. How do you handle resilience and stress management?" And I was like, "Ooh, that seems like I
Very
don't have
cool.
a solution." Clue. And she turned me on to really thinking about breath work. Now, I'm still not a great meditator in the traditional sense. I mean, this has just never been where I've been successful, but really understanding using the power of breathing, which is great for exercise, any modality, but what kinds of different breathing techniques that we have available, and we have some of them have a lot of evidence behind them as a tool for, say, managing stress, kind of improving your overall well-being and resilience. To me, that's a tool that is free, available, and we're already doing it. But if we can maximize it, how great is that? And so that really kind of changed, those sort of things have changed my mindset about how I deliver and why I deliver the way that I do. And again, I don't want someone to go to Google and search sleep and find, here's the $60 a month supplement. To me, like, I don't know, like I find that very predatory, especially on our cancer population when the risks and fear of dying is so high and so front of mind, right?
Yeah.
So I think that I'm just much more protective about that and thinking about what's practical and what fits anybody. So it's a little bit of a different mindset of why I've gone this way, but really followed the science, which is phenomenal, not all encompassing, but we've got good science and we should use it.
It's funny as you're talking, I'm thinking about this a few years back, but there was a younger medical oncologist at a private practice. And he was telling about this one lady that every single time she was like, "Hey, my neighbor across the street said I should try this. You just need to walk. Well, my aunt's doing this. You just need to walk. Well, I saw this online. You just need to walk." It's like, just freaking walk, people. Just freaking walk.
Yeah. Or do something. I don't care
Yeah,
what you
anything.
do.
Yeah, anything.
I
Just
was at a
move.
conference I was at a conference last weekend and I was talking to a lung oncologist, and she's like, "Oh, I love to exercise." And she's Egyptian. So she does belly dancing. And she's like, "Well, maybe that's not like, she's like, I know it's not strengthening, but like that's what I do." And I was like, "That's awesome."
Are you kidding
But
me?
at the
Yeah.
end of the day, I mean, if someone doesn't want to walk or doesn't want to, but I'm kind of like, well, why do you not want to walk? Or, is it, I think a lot of times we tell people go walk around the block. I think they're embarrassed, they're scared, they live in an unsafe neighborhood, they don't enjoy it. So maybe that's not the right thing. But honestly, one of the reasons I've been having a lot of fun with our YouTube channel is because people ask me, like, all right, what do I do in 5 minutes? And I was like, well, I gotcha. And rather than me tell one person, it was like, just make a little video on that. So, like, one of the things we started recently is every Friday we put out the Friday Five. It's a 5 minute workout. It's all different kinds of modalities. And, I tell people, like, no excuses. And it's one of those sort of fun things that someone's going to pick on something and then they're going to be like, I'm not going to do that one. I'll do this one. But it at least helps people think. And I think also kind of look at stuff from the comfort of their home where they don't have to worry about being embarrassed or judged, or they feel terrible about themselves. And I think that's sometimes why people are so nervous about exercise. They're just very intimidated and they don't want someone to judge them. I cannot tell you the number of times I'd want to send someone to rehab because they desperately needed it. And they were so uncomfortable going because they felt so debilitated. They wanted to get stronger to go. Right. And
Yeah.
I'm like, I remember after that happened a couple times, I thought, I'm not explaining this well. I am missing connecting with these patients. And so it really took me kind of digging into understanding the barriers. And so I would tell people, I know you feel embarrassed right now. Like, I know that you don't feel as strong as you were when you came in the door. That's why I want you to go. I just want you to go once. And people would be like, but at least we identified their barrier, not just, I don't care about it. And I think that that's something that we need to do a better job in all of my field, is hear what people say and hear what their thoughts are.
Yeah, it's incredible how much I've learned just in the last few months. We had someone from talking about obesity, bias, and stigma,
Mhm.
and the number one
Yes,
by a very large margin, the number one place for the most bias complaints against bias is healthcare. And
100%.
and as I started talking to more folks that are in lifestyle medicine and obesity medicine, and we also have guests on that have lost 10% body weight or more to talk about their journey. I used to think like,
Mhm.
oh my gosh, like why aren't you exercising? Like I don't care if it's pickleball or swimming or dancing, whatever. Like why aren't you moving? But if you are either if you have obesity, moving
Mhm.
is not comfortable. And then,
Yeah,
on our conversation today, there's a lot of different types of morbidities that come along with having
that's right.
cancer, and that hurts or is uncomfortable or is tiring.
Mhm.
So, like, those are real obstacles that we have to like not skirt
Yeah,
around, just ask, like,
right.
try to figure out it's just so unique for every single person. Whatever type of cancer you have, or what your family dynamics are like, what your professional life is like, and just where you
Yeah.
are. Try to find something that
Well, and
works
I
for them.
wondered, I heard that I was talking to a friend of mine yesterday. I worked with her as a clinical dietitian in a cancer practice. She happens to live in the same area as I do now. And we were talking about like the mindset of, oh, I have to do 150 minutes or 30 days, 5 days a week, or it does not count. And I think that's actually a lot of our like clinicians. And I think that, if we have these recommendations, that's what we're telling patients. We care so much about the recommendations. And I'm like, yeah, I'll get you there. But if I just chase the number, am I doing something meaningful? And I think sometimes like, we get stuck in just giving someone recommendations, but not really again, maybe identifying maybe where they are, their barriers, sometimes their schedule, their innate ability, whatever it may be. But it's like, are we asking them? And are we just too busy trying to tell them how important the recommendations are versus
Yeah.
asking them maybe their thoughts? And then you bring up another thing about bias. So I have very specific types of exercise that I enjoy the most. And one of the things I've learned is I have a bias of, wanting to tell someone like this is the best and having to kind of
Yeah.
take a pause and say, they'll be like, well, I really want to do yoga. Okay, tell me why. Well, yoga for strengthening is maybe going to look a certain way. So it's like, you want to do yoga? Great. Here's where maybe what yoga is going to give you from a benefit, but you want to do yoga? Let's do yoga. But I also want people to be educated where maybe that, yoga is not going to build their bone density, right? But they should still do yoga. But maybe when they're ready, next step once they're with yoga is to do maybe something to build more bone density, whatever that is. But if they come to me so excited about their yoga class or their Zumba class, or their belly dancing or their aquatic aerobics, and I'm like, that's not the right exercise, then I have lost that relationship. And are they going to continue? If I give them like the most excited, it's almost like with children, right? That's amazing. Let's do it. And I think people need that support. We don't live in that sort of positive affirmation. And I think that's actually when we've run the thing that I've really recognized as I run shift with like the live versions where we're coaching groups of people, they come there for the support in the community. And I realized that they're looking for sort of that, positive coach. And it's not like simple and small. It's actually really powerful because I don't think people get a lot of that positive feedback. So whatever it is people do, whatever you're listening and whatever you do today, awesome. Just do it. I don't
Yeah.
care if it's a minute or an hour. So I think that, that's something I've really learned along the way is my biases. I've had to really pause and make sure that I was listening, not just, I want to tell you about the best exercise ever. So a lot
Just
of
start where you
changes.
are. Doesn't matter where you
Yeah.
start. Just start.
hmm
Okay. Oh,
Yeah.
this has been good. This has been a lot of fun. Wow. Is there anything you want to share real quick that we might have missed today before you? I'll just throw that out there real quick.
I really think that the more that I kind of sit back and look at this, like it kind of goes back to we sort of lost the forest in the trees bit when it comes to all of this with exercise oncology and with lifestyle. We're too busy looking for a perfect solution. And I think we've sort of lost the big picture to your point about a little something is better than nothing, or avoiding something less healthy or maybe more toxic for us, whether that's a thing or a person or a habit, is really powerful. So, I think that we innately know some of the things that we should start with. And I think that we've sort of looked for this perfection specifically in the cancer space. And lifestyle is never going to have the powerful evidence behind it that, clinical trials do. Like, that's just not what we do. So I think that, whatever it is you do, whatever it is people engage in regarding any of these, give yourself a huge pat on the back. And I think that it doesn't have to be perfect. And that's why I say that with exercise, like just dig around, see what inspires you. Do that. Just do that.
I love that.
It's
Yeah.
difficult.
Just start. Have a plan so you don't have to think about it. Make it a habit. You can change it anytime you want. Just
Yeah.
make it easy. As you're talking, our mission for Interrupt Hunger, I've held on to this for a while. It's prevent chronic disease, feed the hungry, foster community. I mean,
Yeah.
we forgot how to cook, or we never learned how to cook. Not very many people know how to garden. We're
Right.
really isolated, and it's
Wow.
just getting back to how we used to live several generations ago, taking care of each other and taking care of ourselves.
Um, Jolly, have you seen the research that was just published about cancer mortality and like related to social isolation and loneliness, how significant it is?
No.
So came out at ASCO 2023 as an abstract and then was published. And I'll have to find the research and you can put it in like show notes, but I believe that I know that increases your mortality. The current social isolation for people that report social isolation increases their mortality. I believe it's the equivalent of smoking a pack of cigarettes a day. It's pretty significant.
Wow.
And what it reminds me is when I worked in the cancer space and people were looking for support groups, I found that they weren't often looking for like the sit around and talk about it group. They were looking for a support of hope, camaraderie, and community. They were looking for someone that had been through their journey, that had lived to tell the tale, or can
Yeah.
kind of go, yeah, me too. They were looking for someone to encourage them, like, you can do this, you could do whatever kind of community or support. And the community piece, one of the things I love about community groups and lifestyle is you always know what you're going to get. So it's like that person, that situation, you walk in the door and you just know it's going to be a positive experience. And I don't think we have that guaranteed. There's no Facebook group that always has that. There's no like community, location that always has that. And I think that that's something that that is something people are looking for, even if they can't define it. But if we don't create these things and leverage the work that you're doing, we are increasing, the risk of dying, no matter how good the treatments are. And that to me is very telling. That's social connection seems like a weird lifestyle pillar, but it is really quite
It's
powerful.
very
So
real. Oh, thanks for sharing that. I'll dig
yeah,
into that. That's pretty neat. Yeah,
yeah,
I don't know, my kind of one of my the thing that's driving me now, I fully believe that virtually every problem in America could be fixed if we took better care of ourselves and took better care of each other. I mean, I just care.
yeah.
I mean,
In the world, it could
yeah.
be fixed in the world. Yeah.
All right. Well, this has been pretty great.
All right.
Thanks a lot, Sammy. So
Likewise.
how
Thank
do
you.
people find you?
Yep. So my main website is cancerwellnessforlife.com, spelled FOR. And you can find all of the information about our resources, information about the SHIFT program. And then I'm on various social media platforms, LinkedIn, Instagram, and YouTube. Mostly through YouTube is our SHIFT program. So it's like patient-facing side. So anywhere like that, you can find me. And I try to answer and respond to everything because I really believe that if someone has the courage to ask a question, then at least we'll provide a response or an answer. So
Oh,
yeah,
very
thank
nice.
you so
Wonderful.
much for including me, Jolly. I appreciate it. It's been
This has
a
been
lot of fun
wonderful.
talking about this. Yeah, thank you.
Yeah, thanks so much, Sammy. All right. Have a good one.
You too.
Thanks so much for listening. Please rate and review the podcast on the platform of your choice so we can reach more people and more people are recommended this podcast. And if you really liked it, the single best way you can help us grow is by telling your friends. Now, for all the legal stuff. The views and opinion expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. For my day job, I'm an employee of AbbVie and appear on this podcast on my own accord and not in the professional capacity as an AbbVie employee. All viewpoints provided are my personal opinions and not intended to reflect those of my employer. If you have any questions or comments, please shoot me an email at jollie@interrupthunger.org. Let's go spread some joy, people.